I'm Dr. Bindu Menon, and I welcome you all to this webinar on Learn About Stroke. At the outset, I wish you all very good health, and I also sincerely hope that you are all following strictly the rules and practicing the safety measures during COVID-19 time. As more people join in, it is 6:30 and we move forward with the session. Today, we have all joined here to learn about stroke. Brain is a very complex organ and it serves several functions. And that's the reason, if even a small part of the brain is damaged due to any reason, then that function is at stake. So for example, let us say even if the stroke in the brain is very small, but if the person is not able to hold a pen and if the person has got a clerical job where he starts writing from morning to evening, or for example, if the person is a driver and if a small part of the vision on the lower side is not visible with the stroke, then his future and his activities of daily living and livelihood is at stake. Let us learn about the facts and figures of stroke. According to the World Health Organization, 1 in 4 persons globally under the age of 25, over the age of 25, will be affected with stroke in their lifetime. 1 in 4 is the number which has come, which was earlier 1 in 6. So we can imagine that earlier it was 6 people out of that 1 will develop a stroke in a lifetime, and that has increased to 1 in 4. So that is the brunt of the illness. Globally, it has been found that there is around 13 million and above people who are affected by stroke every year, and of which around 5 million and above die because of the stroke. And of that, around 5 million are confined to bed or are dependent on their daily activities with their family members. Having said that, it is also possible that in 80 to 90% of patients with stroke, the stroke could have been prevented. So that it is extremely important for us to know how we can prevent stroke. So let us know what is stroke first. Stroke happens, we are talking about brain stroke here, and we are not talking about the heart attack, that is a heart stroke. Stroke occurs when any part of the brain where the blood vessel goes, either the blood vessel is blocked or the blood vessel bursts because of high blood pressure. So strictly there are 2 types of stroke. One is an ischemic stroke and second is a hemorrhagic stroke. Ischemic stroke, that is the first type, happens when the blood vessel is blocked either due to a blood clot or either due to a fat particle. The second is when the blood vessel, that is a pipe which is there, is suddenly bursts because of the high blood pressure. Now the first type of stroke is what we would be predominantly discussing here, that is the ischemic stroke, accounts for 80% of patients with stroke. And the hemorrhagic stroke, where the blood clot accounts for around 20% of stroke. As I said, it is important for us to know how to prevent stroke because 80% of strokes are preventable, and stroke is a catastrophic illness which leads to a lot of morbidity as well as mortality. So it is important to know how to prevent it. The major reason behind the stroke is atherosclerosis. Now, what is atherosclerosis? Atherosclerosis means in the blood vessel, when the fat particle starts forming, that is, the blood vessel is like a pipe, and if the fat particle starts forming, when it reaches a critical period where the blood supply gets stopped to the brain, then it is known as stroke. So the underlying portion is most of the times is atherosclerosis. Now, how does atherosclerosis occur? The major risk factors for atherosclerosis which leads to stroke, which has not been seen properly by the patients, are most common is hypertension. Hypertension If it is treated properly, it does not lead to stroke. But if hypertension is not addressed properly, the fluctuations in blood pressure in that particular patient will lead to atherosclerosis and formation of fat within there. It's like a pipe system, and whatever the blood vessels from the heart which goes to the brain, there are 4 major blood vessels that go from the heart to the brain. If any of them stop because of the atherosclerosis, that area will stop having the blood supply. So having said that, we understand that the atherosclerosis does not happen one day, but the stroke happens one day. Atherosclerosis starts over a period of time, and when it reaches a critical period, then only the stroke happens. The foremost is hypertension. Second is diabetes, not controlled, if not taken care of properly. Third is smoking. Fourth is alcohol consumption. Fifth is increased cholesterol in your blood. Sedentary lifestyle. Central obesity, that is increased body weight with central obesity, increased body mass index. Cardiac factors, cardiac risk factors, there is valvular heart disease or any of the coronary artery disease patients. Atrial fibrillation. And then come the lesser known risk factors like patient with high stress levels, poor lifestyle in the patient, obstructive sleep apnea, and pollution, which we will be discussing. Hypertension being the most common and the most foremost thing, 80% which could have been prevented, is by salt restriction. Mind all of you that the salt restriction does not start when you're more than 40. The salt restriction should start when you are at the teenage level. That is, we should instigate that in our children itself. A person is allowed 5 grams of salt in a day. So how much is 5 grams of salt? It's just a small teaspoon, not like a hillock of a teaspoon, just a small teaspoon throughout the day. So if the person for example, takes a snack, takes another kurkure pack, potato chips, and takes some other snack in the evening, it eventually amounts to around 6 to 7 grams of salt every day. So the cumulative amount of salt that the person takes accounts for hypertension when the person reaches at around 40 years or so. So salt restriction is very important. Moderation, that does not mean stop the salt, because low salt is also not good for health. Normal person is allowed around 5 grams of salt, and if a person is hypertensive, he should be taking around 3 grams or less. The second is diabetes. Diabetes, if not controlled, if not taken care of in time, it also leads to atherosclerosis and needs to be under a diabetologist strictly. Smoking is one of the major risk factors. Earlier, we used to have patients who had stroke who were more than 60 or 65 years. But now we are seeing that 20 to 30% of stroke in our stroke registry, as well as all across the country and overseas, we see that young stroke are, that is between the age of 25 to 45 years. Now, why is that happening? Is because of the bad lifestyle and the habits which the people are cultivating. Now, smoking, it is important how many packets or how many number of cigarettes or BDs or tobacco, that is the smoke, as well as the smokeless form, the person consumes. It is also important to know about the pack years. Pack years accounts number of cigarettes, BDs or tobacco which the person has taken and how many years the person has been consuming. So if a person takes 10 cigarettes in a day for 20 years, or if the person takes 40 in 5 years, would account the same. So you understand the number and for the duration of time that the person is taking. Alcohol consumption is a strict no, and the person should refrain from taking alcohol. Sedentary and lack of exercise has been found to be a major contributor now in this era to be a cause of stroke. Central obesity is very important. That is the fat across the belly. That is known as central obesity. And this central obesity has been found to be very important which is linked to the atherosclerosis. So sometimes a person may look very lean, but the central obesity would be the link to know that the person can have atherosclerosis. Sedentary lifestyle and lack of exercise. A person should be walking at least 30 minutes, 5 days in a week, and the walking should be to the moderate degree where the person can still talk while the person is walking, but the person can sweat, but then his voice should not break. That should be the magnitude, because most people ask how much I should walk, what should be the speed of my walking. One, before you go for walking, you should take an consultation with your doctor if you have a cardiac ailment or any knee problem or any other orthopedic problem. Leaving aside that, a person should walk for half an hour to the speed which he can, and that too, it should be for the degree which he can talk to another person without much difficulty. That is the amount of walking he should have. It has been said that if a person sits for 8 hours without moving around, it is equal to smoking 1 pack of cigarette in a day. So you can imagine that that is the amount of burden of atherosclerosis a sedentary lifestyle would be creating. Then, having said that, dyslipidemia, that is high cholesterol in the blood, can eventually, that comes from eating habits as well as lifestyle, that is your walking and other exercises. Cardiac complaints are an important factor. Cardiac complaints, if the person alveolar heart disease, that is valve problems are there, then the person would definitely be on blood thinners. If the patient does not take those blood thinners, then the blood clots in the heart, and from there, from one of the major vessels, goes to the brain. If the patient is a cardiac patient for which he has undergone either a stent or has gone a CABG surgery, for which he has been prescribed medications and is not taking the medication, again, the atherosclerosis starts off from there, and then the patient can have the same atherosclerosis which is there in the body, which has hurt his heart, which can happen to the brain as well. A very important risk factor which are seen in elderly, that is known as atherosclerosis. Apart from that is known as atrial fibrillation. Our pulse beats at a very rhythmic rate. The rhythm has to be very important. It doesn't beat, it's like a clock, it beats in a very rhythmic state. For some reason, if our rhythm is not, the pulse rate is very high, then it is called as atrial fibrillation. The symptoms which the patient can have in fibrillation is the patient can have palpitations, the patient can have sweating, and the patient can suddenly fall down. That can only be known if the patient gets to the doctor, and there are certain tests which can be done by which we can find out whether the atrial fibrillation is there or not. And this is one very important cause in the elderly. Why that is important? Because the treatment modality is different. Leaving aside the conventional risk factors which lead for 80%, the other important risk factors which are emerging, which are lesser magnitude but which are very important, are obstructive sleep apnea. In people who are obese, or sometimes for other reasons, when they snore in the night, and if the snoring is it is too much, that is the severity of the snoring is too much, then they tend to block the windpipe, and in turn the blood circulation, and for a fraction of a second it gets curtailed to the brain as well. During those times, if it keeps occurring again and again, there is a possibility that the person is at a risk. He will not develop stroke. He is at a risk for brain stroke as well as for cardiac stroke as well. Two more emerging factors have been found. One is pollution. The World Federation of Neurology has staunchly saying that pollution has to be looked into. And now we can see that we are not only responsible for our own health. Today, this COVID-19 pandemic, we can see that we are not only responsible for our own health, we are also in turn responsible for the other person's health. So it is a collective way that we can see that to stop pollution. And everybody knows how to stop pollution. Only thing, we need to work on it, because in the cities, it has been found around 10% of the stroke in the young as well as in the old are being attributed to pollution. Depression is looming large and is sort of superseding the other risk factors, because in a person who has depression and lot of stress with other comorbid risk factors, the person becomes more at risk for developing a stroke. So now how do we do in general to see that these risk factors do not play and does not lead to a stroke in a particular individual? It is not so difficult to see about that. Only thing is that a person has to follow that. So one is restriction of salt and oily food in the diet. Salt, as I said, 5 grams and 3 grams in persons with hypertension. Limit of oil, it should be an unsaturated fatty acid. It should be a refined fat, which one should be taken, and that should be in moderation. Exercise should be a daily routine. One should not be continuously sitting in the workplace as well. As I said, continuously sitting is a harbinger for atherosclerosis as well. Post 40 years, one should have a regular checkup, at least one checkup to know whether the person has hypertension. Sometimes one reading of blood pressure might not be sufficient. And if there is a strong family history of stroke there's a strong family history of stroke or cardiac ailment, or for that matter, hypertension, because environmental factors play, what the whole family eats, what the whole family does, the whole family has. So it is very important to have oneself checked up, because it is not just the blood pressure that may matter, because a simple ECG and a 2D echo in some can tell us what is the condition of the heart, whether there is a hypertension, where there are some telltale signs in them. There are some telltale signs in them. So one needs to have a checkup post 40 years for the hypertension, the diabetes, the cholesterol levels in the blood, and if needed, if there is a family history, to have a cardiac checkup also done. If there are several risk factors in a particular individual, then there are certain other tests which can be done to know whether there are any atherosclerosis in the major blood vessels, and they are known as carotid and vertebral Doppler. We have a stroke riskometer, by which we check the hypertension, we check the blood pressure, we check the body mass index, we check the obesity level, we check the level of activity in the person, we check the ECG of the person to see if there is any strain pattern which suggests that the patient has hypertension, and then we try to find out if the person is under a risk, so that the person can undergo another test known as a carotid and vertebral Doppler. That is the blood vessels from the heart to the brain, whether there are any blocks which are starting at that age. And then medications, apart from that, recommendations which can be tuned to the patient can be found out. So that is about prevention. Now, what should one do when a person has a stroke? How does one stroke? Because it is very important, because time is brain. Every minute that after the person has developed stroke, every minute that we are losing, almost 1.9 million neurons are being lost every minute. So it is very important recognition of the stroke symptoms are done, and the person reaches the hospital, that is the stroke ready hospital, in time. Now, to know the symptoms of stroke, one, it is sudden. It happens suddenly. The name itself suggests stroke. As I said, all the factors which were leading to stroke were there in the body, but then the symptoms come out at one point of time. The person would have been absolutely all right 1 hour back, but then at that 0 hour, when the patient starts having symptoms, it is necessary for us to know that these are the symptoms of stroke, because within 4.5 hours, that is the golden window period of stroke treatment for the first type of stroke, that is the one which the blood vessels were blocked, that is the ischemic stroke. Not all patients, obviously, but majority of the patients, within 4.5 hours, if the patient is taken to the stroke ready hospital, there is a treatment called as thrombolytic therapy. That is that lysing, that is the clot lysing drug, that is the clot buster drug can be given to the patient. In selected patients, again say in selected patients, that is the first type of patient, even then the selected patient, because there would be some indication, contraindication. So how do we recognize stroke? One, it happens suddenly. There is a mnemonic which has been given, which will help us to recognize stroke in most of the cases, that is B fast, BEFAST. So B stands for balance. Sudden onset of imbalance. If the person is walking, is not able to walk properly, he's tending to sway to either sides, or when he's taking a, let me say, if he's holding like this, the glass or something is going like this. If he's holding the spoon, it is going like this. If he's holding his phone, it's going like this. Imbalance. Balance. Balance. E for eye. Sudden onset of vision loss in either one eye, or unable to see one side. So like if I'm looking at you, I'm able to see everything as one picture. But if suddenly I'm not able to see one side, and if one side looks blurred to me, it could be stroke. Any of these symptoms, it could be stroke. In eye itself, if a person suddenly sees double, like if I'm seeing this laptop, I'm seeing this image, one more image next to that image is there, which is overlapping like this, then that is for eye. B for balance, E for eye. BEFAST, F for face. When one is talking, when we smile, let us see this, when we are smiling, there is a nasolabial fold which is equal on both the sides. But if the person starts developing stroke, he can be having a little bit facial deviation. That is, the face would be deviated to one side, and the folds will not be equal on both the sides. That is F for face. A for arm, that is, if the person's arm, usually we say if the person has a stroke, immediately ask the person to keep both the hands in front, and if one of the hand keeps going down like this, then the patient could be having stroke. Again, I say it could be, because there could be several other reasons. Unless the person reaches the hospital in time, we cannot know what's happening to the patient. So that is A, that is weakness of the arm as well as leg in that. S is for B fast. S stands for speech. In speech, there can be three. One is suddenly the patient becomes mute. He doesn't talk. He doesn't speak anything. That is for speech. Or the patient could be speaking in a jargon language. That is, I ask, how are you? What happened? Do you want anything to eat? And the person replies like, what is happening? Why is the tube light on? Who is there? What is? So there is a disconnected speech. The person appears confused. This could be another form of stroke. Or the patient understands but is not able to reply back to you. These are the for S. And the last one is T. As I said, T, time is brain. Every minute that the person is at home and not brought to the hospital, every minute millions of neurons are continuously dying, and those death of the neurons could be permanent if they are not addressed in time. So be fast, remember the mnemonic. B is for balance, I is for eye, is for vision, any of those features which I said. F is for face, A is for arm and leg weakness, S is for speech, and T is for time. Apart from that, one-sided numbness, that is face, arm, trunk, leg, one-sided onset of numbness could be a form of stroke. A sudden severe headache, first time in the life, that is the start and the peak of the headache. It is so severe that the person has not experienced a headache of that sort. Severe giddiness in which the person feels that everything is moving around him. These could be other forms of stroke. Recognition of the stroke is very important. As I said, the person should be taken to a stroke-ready hospital. If somebody has a stroke symptom like this, where should the patient be taken to? Now, a person is very, very comfortable with his family physician and wants to go and visit the family physician and wants to find out whether this could be a stroke. But then we are wasting on time here, because the family physician will need to check, the family physician will need to examine the patient, the hypertension, blood pressure and everything. And by the time that the patient reaches the hospital, he would have lost another half an hour to 45 minutes. And we have only 4.5 hours window period. That is the golden period of stroke thrombosis. That is intravenous thrombolysis which the patient can be given. So it is always better to take the patient to the stroke-ready hospital. That is the stroke-ready hospital wherever the patient, most of the times it is difficult for a person to know which are the stroke-ready hospital. So for in general, the hospitals which has got imaging facilities, one should take the patient to that hospital. Now, what happens when the patient goes to the hospital is that we find out with the neuroimaging whether the patient has got the first type of stroke or the second type of stroke. And it is always important, we tell the relatives while you are in transit, always keep ready all the records. So it is not possible at that point of time when somebody is in a hurry to take all the records. We understand. That is why it is always important, anybody who is on a long list of medications, it is very important for us to know that what are the medications you are taking, because there can be some contraindications and we cannot give the medication that is a thrombolytic therapy. So a gentle advice to everybody is that if the person, any person who is on long list of medication, this is very handy for us. And this is always kept with us. We always have it with us. So always take a snapshot of the doctor's treatment every time with you. Nobody forgets this. Everybody. So when you reach the hospital, you have the latest records, you have the latest medications, it becomes very easy for us. Otherwise, by the time you reach the hospital, then we find out whether you're already on blood thinners. So whether we give this medication or not, it takes a lot of time. Within the 4.5 hour period, if for eligible patients, around 30 to 40% of patients will improve within the hospital setting. So how good it is, how good it is. I understand that a majority of patients might not improve, but one of those patients could be under the 30 to 40% if they have been bought in time. So within that period, if they are given, that is a clot busting therapy is given to those patients and they can make an improvement, remarkable improvement while they are getting discharged. And a majority of the patient, if you see within the 3 to 6 hours, 3 to 6 months, when they come back for follow-up, the persons who have been given the thrombolytic therapy, their outcome, and the persons who have not been given the thrombolytic therapy and reach the hospital very late, both patients' outcome and the prognosis is different. There is a marked difference between both of them. Apart from that, there are newer modalities of treatment. If the patient does not reach in the 4.5 hours window period, if the blood vessel, as I told you, large blood vessel, if they are blocked and if they have not been opened, if they reach after the 4.5 hour period, but less than 14 to 15 hours window period, in some of the comprehensive stroke centers, there are certain mechanical thrombectomies which can be done. But they are in very selected number of patients, in selected group of patients, but then it is possible in some patients. Now, does the stroke care end here? Does the stroke care after giving thrombolytic therapy end here? No, it does not end. It is a very comprehensive care that the patient should receive, because after the stroke, as I said, the individual patient, whatever the deficit in there in the patient, it could be weakness of one side, it could be speech, it could be vision, it could be dysphagia, that is swallowing difficulty, it could be balance, it could be posture. N number of problems are there for the patient, and for that, we have a comprehensive stroke care, which includes the physiotherapist, which includes the occupational therapist, which includes the speech therapist, and which also includes the psychologist in some cases. Because if the care of the stroke patient is not addressed properly, the patient can have post-stroke complications, and that is known as spasticity. One side of the limb can be stiff, and you would have seen patients walking with the hand like this and the legs, and it is very painful. Even the shoulder can become very painful. They can't lift, they can't unfold their arms, and then you need to have certain other orthopedic treatment given for the patient for the post-stroke complication, which could have been dealt with if the patient had undergone a proper physiotherapy well in time. The patient can also have some other factors coming in if the patient's other diseases, that is other comorbidities, are not addressed well in time. Post-stroke, the patient needs to be on the antiplatelet agent, that is the blood thinner, so that the blood does not again clot there in the blood vessel. He needs to be on statin, that is a cholesterol lowering drug. He needs to be obviously on the hypertension and diabetic medication. But in most of the cases, we see after a period of time, the patients and the relatives, they continue on the BP and the diabetic drugs, and they stop off the antiplatelet and the statin, that is the two drugs. But the two drugs are very important. If they are stopped, there is a possibility, not a possibility, the patient is at a high risk of another stroke. For the stroke treatment, for the stroke physiotherapy, actually during this COVID-19 times, from Dr. Bindu Menon Foundation, we have started a stroke help. And from our website, you can see drbindumenon.com. You can go down to stroke help, where stroke videos by neurophysiotherapists, we have videoed them. Patients can log into that and with the user ID and password, and can do the physiotherapy at home, because that is very important. If the person has got carotid stenosis, that is, there are blocks in the large blood vessel, there are certain modalities of treatment like stenting, which we used to do for the heart earlier, that can be done for the brain also. That is, the blood vessels, if they are completely blocked, there is no way that the blood tablets which we are given are going to dissolve that atherosclerotic plaque. So in some, there is a need for a stenting, or there is a bypass surgery which is done, that is known as the carotid endarterectomy also. Stroke is an illness which leads to a lot of morbidity as well as mortality. The plasticity of the brain only occurs if the management is given at that point, that is acute and post-stroke care. Even if a small part of the brain is damaged and the patient is at home, the whole family suffers, because if the person is an earning member, then he cannot go to earn. If the person is not an earning member, then he has to take care of the person who has got stroke. It's always important to prevent stroke, and the NCD this year, in fact, this is the week where prevent stroke, prevent all the NCDs week, it is there, and this is the right time where we are trying to get into the public and trying to tell them that it is important to prevent, because once a stroke has happened, the morbidity of the disease is very high. Take care of your brain. It is also important, apart from being physically active, it is very, very important to be mentally active, because most of the times now we see people are, most of them are depressed. There are a lot of work stress. People are dumping themselves with a lot of work. There is less of family time. And there is less of entertainment, less of self-care. A gentle reminder to everybody is that you may be exercising, you may be taking care of your hypertension, you may be taking care of your diabetes, you would be eating good diet, but then what about your brain? What about your mind? Are you taking care of it as well as you would be taking care of your body? So it is very important that you remain happy, so that there are good chemicals in the body which help you to keep the physical workout which you are doing and the good diet which you are taking, and they are in the brain and the mind and the body is in harmony. Prevent stroke, recognize stroke, take the patient to the stroke ready hospital by responding to the stroke symptoms. Join hands with us to bring down to stroke and reduce the stroke by half. Thank you very much. Now I would request, we are very thankful that we had almost 100 plus questions and 300 registrations. There were several questions probably which are addressed in our talk itself, and the questions which have not been addressed, I would request Dr. Bishwajit to kindly address it to me so that I can take it one by one.
Surely, ma'am. Thank you, ma'am. It was a wonderful talk. And to our audience, we have received several questions regarding stroke details. That is the types, prevention, treatment patterns that has well covered by our doctor. So we'll take up other questions. So, ma'am, our first question from one of our viewer is, what are the symptoms before stroke? And the preferred language is Telugu.
పక్షవాతం వచ్చే ముందు మనకి ఏమీ సిమ్టమ్ ఉండదు. పక్షవాతం స్టార్ట్ అయినప్పుడు మాత్రమే మనకి సిమ్టమ్స్ వచ్చేది. ఎందుకంటే పక్షవాతం వచ్చే ముందు మనకు వార్నింగ్ సైన్స్ ఓన్లీ ఒక కేసులో ఉంటుంది, దట్ ఈస్ నోన్ యాజ్ TIA. దాంట్లో మినీ స్ట్రోక్ మనం చెప్పేది. ఇంతకుముందు నేను టాక్ లో చెప్పే ప్రకారంగా బీ ఫాస్ట్, మనకి బ్యాలెన్స్ తప్పు పడితే, హ్యాండ్ లో బ్యాలెన్స్ సరిగా లేకపోతే, కంటి చూపు తగ్గిపోతే, ఒక పక్క మనకు చూడ్డానికి ఇబ్బంది అయితే, మనిషిని వస్తువులు రెండుగా కనిపిస్తే, లేదంటే మసగ్గా కనిపిస్తే, ఫేస్ ఒక పక్కకు వెళ్ళిపోతే, లేదంటే మాట్లాడడానికి ఇబ్బంది అయితే, మాట పూర్తిగా ఆగిపోతే, లేదంటే పిచ్చి పిచ్చిగా మాట్లాడటం ఉంటే, ఒక్క పక్క తిమ్మురుగా ఏమైనా ఉంటుంది. ఇటువంటి ఏదైనా సిమ్టమ్ వచ్చి ఒకవేళ మనకి ఈ విధంగా సిమ్టమ్ ఒక 5 నిమిషాలు 10 నిమిషాల్లో ఆగిపోయిందని అనుకోండి, కానీ అది కూడా స్ట్రోక్ సిమ్టమ్ ఉండొచ్చు. ఎందుకంటే లో షుగర్ లో కూడా ఇలాగా ఉండొచ్చు, వేరే కారణాల్లో కూడా ఉంటుంది, అలాగే ఉండొచ్చు. కాబట్టి మన హాస్పిటల్లో వెంటనే వెళ్ళాల్సి వస్తుంది. అది స్ట్రోక్ ఉందా లేదా అది చూసుకోవడానికి హాస్పిటల్లో మనకి టెస్ట్ ద్వారానే మనకి తెలిసేది, వేరే ఏది తెలిసేదానికి ఉండదు. Bishwadit, I just want to speak this in English as well, because
Sure,
any of the symptoms which I had said in the mnemonic BEFAST, BEFAST, for some reason, if the patient gets those symptoms and then the symptoms, he recovers on his own, let us say, under 5 to 10 minutes, the patient becomes all right. What would one do? Would they sit at home, or should they go to the hospital? They should go to the hospital, because this is known as transient ischemic attack. So any of these symptoms which has happened suddenly, be fast. If this happened and then they have recovered and they are completely all right, they should still be going to the hospital, because we need to stratify the risk of another attack in a patient. This is a mini stroke, and in our language we call it as transient ischemic attack, because the risk of a next stroke in day 2 to day 90 can range from 1% to 17%. They need to go to the hospital.
Thank you, ma'am. Okay, ma'am. So our second question is, what are the early stage treatment for stroke?
What are the early stage treatment for stroke? When the patient has a stroke, then only the treatment can be started. And as I said, there are no first aid for stroke. There is nothing that we can say. If the person has a stroke, if the patient or the relative picks up the phone and says, XYZ is having these complaints, doctor, can you suggest a treatment now? No, I cannot suggest a treatment now, because the best treatment is rush to the stroke ready hospital. Time is brain. You are wasting your time or even calling. So get to the hospital, because we need to know whether the patient has a stroke or a stroke mimic. And only once you get to the hospital and we quickly take a neurological examination, have an NI stroke scale for him, get him into the scanner and find out if there are other things, whether sugar is low, whether his sodium is low, whether his blood pressure is high, what we can do. So we cannot do anything except rushing to the hospital. There is no first aid for stroke. The best aid is rush to the hospital.
Sure, ma'am. Yeah. So, ma'am, one of our viewer wanted to know what can a non-medico do to handle that kind of a scenario? and the preferred language is Hindi.
हाँ, जैसे मैंने बताया आपको कि जब स्ट्रोक के सिम्टम्स आते हैं तो बेस्ट इज जो बाईस्टैंडर रहता है, एक तो उनको क्या क्या तकलीफ हुई है वो देख लेना। जैसे मैंने बताया, फेस एक मुंह एक तरफ तो नहीं जा रहा, हाथ कितना वीक है, जैसे अपना हाथ ऊपर रखा तो हाथ नीचे चला गया, जब तक वो हॉस्पिटल जाएंगे तो हाथ हिला ही नहीं पाएंगे। तो हमारे लिए इम्पोर्टेंट होता है कि आधे घंटे की जर्नी में जब आप घर से निकला जो भी पेशेंट, जब उसका हाथ इतना तक आता था, नहीं तो इतना तक आता था, अब पूरा भी नहीं आता है, पेशेंट पूरा भी हाथ नहीं हिला पा रहा है ना, तो वो हमारे लिए इम्पोर्टेंट। टाइम ऑफ द ऑनसेट, जिस समय तकलीफ चालू हुई हमें बहुत जरूरी है, क्योंकि हम जैसे हमने बोला 4.5 घंटा का टाइम है, और टाइम हमारे बहुत इंपॉर्टेंट है कि इसी टाइम पीरियड में हम वो क्लॉट बस्टिंग वो पतला करने के लिए हम वो दवाई दे सकते हैं। वो टाइम निकल जाने के बाद कुछ कंडीशंस में हमको स्कैन्स में पता चल जाता है कि इस पेशेंट में भी दिया जाता है, बट इन जनरल हमारे को टाइम बहुत इंपॉर्टेंट। तो बाईस्टैंडर एक तो टाइम नोट करेगा, और क्या तकलीफ, कितना तक था तकलीफ, क्या पेशेंट चल पा रहा था, क्या पेशेंट ठीक से बैठ पा रहा था, हाथ उठाता तो कितना था, मुंह कितना तरफ था। 2-3 सवाल पेशेंट को पूछें जब तक आप पेशेंट को गाड़ी में रख के उनको ट्रांसपोर्ट करते हैं हॉस्पिटल तक। तो 2-3 सवाल, जैसे नाम बताएं, 1 से 10 तक गिनती करें, बच्चों के नाम बताएं, तो क्या कितना तक आपको जवाब। जस्ट सिंपल, डोंट स्ट्रेन द पेशेंट, एंड मोस्ट इम्पॉर्टेंटली आप पेशेंट को मुंह से कुछ ना दें। The first aid is do not give anything to the patient by mouth if the patient has a stroke, क्योंकि उस समय जब पेशेंट को स्ट्रोक होता है उनको निगलने की तकलीफ भी रहती है, जो हमें पता नहीं चलता। तो बहुत टाइम में थूक बाहर निकलता ऐसा दिखता है। क्या होता है, उसी टाइम पे हमारा जनरल सेंटिमेंट इज टू गिव द पेशेंट वाटर। जब हम पानी दे देते हैं तो वो पूरे सांस की नली में, पूरे सांस के फेफड़ों में चली जाती है। तो अपार्ट फ्रॉम द स्ट्रोक के अलावा पेशेंट को यहाँ पूरा निमोनिया से भर जाता है, एंड दैट वुड बी डिफिकल्ट फॉर अस टू कट इट। सो टाइम ऑफ द स्ट्रोक, सिम्टम क्या क्या था वो देखें, पेशेंट को कुछ ना दें, जल्दी से एम्बुलेंस को बुलाएं। आपके पास गाड़ी है जिसमें आप पेशेंट को हॉस्पिटल के ले जा सकते हैं, गाड़ी में जाएं इफ इट इज अ कंफर्टेबल थिंग। पेशेंट को पूरा ऐसा लिटा के ना लेके जाएं, पेशेंट को 35 डिग्रीज तक हेड हाई करके जाएं, ताकि अगर पेशेंट को वॉमिटिंग हुआ, कुछ हुआ, तो पेशेंट साइड में सारा बाहर निकल जाएगा। सो दैट इज द फर्स्ट एड विच यू कैन डू एज अ पर्सन। एंड हमारा बोलना है कि जो साथ में रहता है अगर ये चीजें ठीक से करता है तो हमारे लिए बहुत आसान रह जाता है। जब तक पेशेंट घर हॉस्पिटल आता है तो एवरीथिंग इज इन प्लेस, यू नो, हमको जल्दी जल्दी से हिस्ट्री मिल जाता है, पेशेंट का दवाइयाँ क्या है पता चल जाता है, पेशेंट ने कुछ भी पिया नहीं रहता है तो सांस के नली से हमको कुछ निकालने की जरूरत नहीं पड़ती।
Thank you, ma'am. So, ma'am, one of our viewer also wanted to know, his question is, what are the symptoms of an upcoming neurological disorder and how to differentiate between a psychiatric and a neurological problem? And the third question is, can a psychological disorder leads to stroke? And the preferred language is Telugu.
Yes. మీరు అడిగేది మానసిక వ్యాధి, నరాల వ్యాధి, న్యూరాలజికల్ డిసీజ్, మానసిక వ్యాధి రెండు సెపరేట్ వ్యాధిలేనండి. మానసిక వ్యాధి వల్ల పక్షవాతం రావచ్చు అని అడిగితే, యాజ్ నేను స్పీచ్లో చెప్పే ప్రకారంగా మరీ ఎక్కువ డిప్రెషన్ ఉండే పేషెంట్కి వాళ్ళకి బ్లడ్ ప్రెషర్, డయాబెటీస్, కొలెస్ట్రాల్ ఇదన్నీ పెరిగే అవకాశాలు ఉంటుంది. అది కాకుండా మెడిసిన్స్, ల్యాక్ ఆఫ్ యాక్టివిటీ, ఫిజికల్ యాక్టివిటీ ఉండదు, వాళ్ళకి ఉత్సాహం ఉండదు, ఏది చేయడానికి వాళ్ళకి చేత కాదు, అండ్ విత్ డల్నెస్ బాడీలో వచ్చేటప్పుడు ఇటువంటి వ్యాధులు లైక్ బ్రెయిన్ అండ్ హార్ట్ స్ట్రోక్ వచ్చే అవకాశాలు ఉంటుంది. అది డైరెక్ట్గా లింక్ ఉండదు, కానీ అది ఇండైరెక్ట్ లింక్లో పేషెంట్కి వచ్చే అవకాశం ఉంటుంది. సో సివియర్ డిప్రెషన్ ఉంటే మనకి కష్టమే అవుతుంది. రెండు వ్యాధులు డిఫరెంటే. న్యూరాలజికల్ డిసీజ్ అండ్ సైకాట్రిక్ డిసీజ్ వేరే వేరే. ఎందుకంటే న్యూరాలజికల్ డిసీజ్లో వచ్చే వ్యాధులు అంటే మనకి పక్షవాతం, మూర్ఛ వ్యాధి, న్యూరోపతి, స్పైనల్ కార్డ్ డిసీజెస్, ట్రాన్స్వర్స్ మైలైటిస్, మయస్థీనియా గ్రావిస్, పార్కిన్సన్ డిసీజ్, ఇదన్నీ సెపరేట్ డిసీజెస్ ఉంటుంది. మానసిక వ్యాధిలో సిక్సోఫ్రీనియా, బైపోలార్ డిసీజ్, మానియా, అంటే దాంట్లో సిమ్టమ్స్ కూడా వేరేగానే ఉంటుంది. ఇటువంటి కొంతమంది పేషెంట్స్కి డిప్రెషన్ అనే సమస్య రెండిట్లో ఉండొచ్చు. అంటే సైకాట్రీ వ్యాధిలో కూడా ఉంటుంది అండ్ పేషెంట్స్ స్ట్రోక్లో కానీ మిగతా వ్యాధిలో ఉన్నప్పుడు కూడా మామూలుగా మనుషుల్లో కూడా డిప్రెషన్ ఉంటుంది. సో ఐ కెన్ అండర్స్టాండ్ ఏదైనా వ్యాధిలో ఉన్నప్పుడు వాళ్ళకి కూడా ఉండొచ్చు. సో దే ఆర్ అబ్సల్యూట్లీ డిఫరెంట్. నరాల వ్యాధి వచ్చే ముందు మనకి ఏమన్నా నరాల వ్యాధి వస్తుందా తెలుసుకోవడానికి యాజ్ ఐ సెడ్ మనకు రిస్క్ ఫ్యాక్టర్స్ ఉంటే రిస్క్ ఫ్యాక్టర్స్ని మనం సరిగా కనుక్కోకుండా దాన్ని కరెక్ట్గా మనం పెట్టుకోకపోతే ఇట్ ఈస్ పాసిబుల్ దట్ స్ట్రోక్ కానీ వేరే సిమ్టమ్స్ స్ట్రోక్ ప్రిడామినెంట్లీ స్ట్రోక్ వచ్చే అవకాశాలు ఉండొచ్చు. సో పేషెంట్కి రిస్క్ లెవెల్ పెరుగుతుంది.
Thank you, ma'am. So one of our viewer asked a question: Can diabetic and gastric trouble leads to heart stroke or any neurological problems?
As I said, diabetes, if it is not controlled, can lead to atherosclerosis, and that can lead to a stroke. But gastric problems per se are not a risk factor for stroke.
Okay. So, ma'am, so related to gastric problems, so our next question would be, what type of diet is to be preferred by a person to avoid stroke? Or this question is specifically, what type of diet is to be avoided in stroke, basically? So the preferred language is Telugu.
So what we say is that every person should have a healthy diet. But a person with stroke should be extra careful about his diet because he already has an atherosclerosis in his body and which can increase, obviously. So anybody can understand that. A healthy diet contains, as I said, one is salt. Salt is extremely important. We always recommend that the amount of salt in the food should be 5 grams, and as I said, it's a small teaspoon. And if you are hypertensive, it's less than 3. You should not stop salt because most of the times we see that sometimes people are extremely aggressive in the salt restriction and they'll end up with hyponatremia, that is low sodium, and become drowsy and come to the emergency. So you should be having a balance. Eat portions of fresh fruit and vegetables. It is very important to have portions of those diet. Eat all fruits and all vegetables in different colors because the amount of micronutrients, minerals, vitamins, and metals, trace elements, everything is different in every food. That's why God has made all these fruits and vegetables in different colors. That's what I always say, that otherwise these colors would not have been there. So every color denotes a different element. Eat that. In oil, you should be taking refined oil. You should be taking in moderation, and it should not exceed because that is how the amount of the type of food you eat is also very important. Sometimes most of the time it is seen that some risk factors come in the family. As I said, it is environmental, what the whole family eats, what the whole family exercises, what the whole family does, the whole family suffers. So if the whole family eats good food, we have seen that the risk factors are also less, and that's why deep fried items should be in very moderation. That deep fried, I mean samosas, bondas, what do you call, vadas, all those things should be in less and less and in moderation if the person has a stroke. Now when we come to non-vegetarian diet, as we understand, the red meat is very high in cholesterol and should be absolutely avoided. That's what we feel. And chicken and poultry, once the person has 6 months and has sort of stabilized, can take it once in a while. Otherwise, that should be avoided in the acute period of a stroke. Egg white can be taken and fish can be taken in moderation, provided it is not from the sea and there's not much of salt in that.
Right, ma'am. Ma'am, one of our viewer wanted to know more about sigmoid sinus thrombosis and the chances of recurrence of stroke.
Absolutely. Yeah. So now whatever we have spoken today is arterial stroke. So for everybody, for the viewers, we have got 2 types of blood vessel. One is the blood vessel that takes the blood from the heart to the brain, and the blood vessel which takes away the impure blood from the brain to the outside the brain. That is called veins. And what the viewer was asking about is sigmoid sinus thrombosis. So what we had spoken about is the blood vessel which takes from the heart to the brain when they become blocked. The question is about the veins which come out of the brain. They can also produce stroke, but the reasons for the stroke are absolutely different in them. They are usually seen in our country because of anemia, that is low hemoglobin, postpartum stage, that is post delivery. Most of the times it is because of anemia and poor nutrition in the women. It is also seen in smokers whose hemoglobin level is very high and the blood becomes thick and it is not able to travel across the veins. Then there are inherent certain blood dyscrasias and blood coagulation defects in the blood itself, which can produce that. Now, whether the person can get a sigmoid sinus thrombosis yet again, that is a recurrence rate. As we said, for arterial stroke, there are certain tablets which are lifelong, that is antiplatelets and statins, hypertension, diabetes. Now, for sigmoid sinus thrombosis, it depends upon the etiology, that is the cause. If the person had a severe anemia and postpartum state, patient's hemoglobin was very low, and that is why the person developed a sigmoid sinus thrombosis. Most of the times, once the sinuses have cleared and the hemoglobin level has attained its normal value, the person need not take lifelong medications. Depending upon other factors, if the patient has fits and everything, then that is managed at its own level. But if the patient has clotting factor, genetic defects in the blood itself, then the patient needs to be on blood thinners for this individual lifelong. Otherwise, he can be at a risk of another. That is a venous stroke. That is known as venous stroke, and the one which we spoke are known as arterial stroke.
Right, ma'am. Ma'am, one of our viewer has given a clinical scenario, like if a 18-year-old guy gets a stroke and he doesn't have any history of smoking and drinking habit. So can you explain that, explain stroke in that case?
Yes, because as I mentioned, in the earlier ages, stroke was said to be disease of the aged. That is, patients who were 60 and above were known to have stroke. But now 10 to 30% patients, we are seeing it in young age, that is stroke in young. Our registry itself has got around 10 to 20% patients who are young in age. That is usually because of the bad lifestyle in them. Could be. Now, I'm not mentioning about that particular individual because every person is different. If the person doesn't have hypertension and diabetes, then we need to check on his lifestyle. We need to check his level of activity. And then there are certain other causes of stroke apart from the atherosclerosis. We need to check his heart, whether there is any valvular heart disease, whether there are other rhythm disturbances in the particular individual. Then there are certain angiitis, which we say, that is in the blood vessel itself. There is an inflammation because of which the blood vessel volume becomes narrow. Or there are certain coagulopathies which the patient should undergo certain testing, that is blood investigations, which we will come to know. So the etiology in young stroke could be different if the person is not having the regular known risk factors for atherosclerosis, but the different etiologies needs to be worked out in detail because the treatment modality for that particular individual is also different.
Thank you, ma'am. So one of our viewer asked, the next question is, in the left arm to left ring finger, there is numbness and tingling sensation. So is it possible that it can be due to ulnar nerve defects or pain?
Yes. As I said, there could all be stroke mimics. Stroke happens suddenly, you know. These symptoms don't come go like that, and specifically at that area, if it is only one finger, very unlikely to be a stroke. And if it has been going on for a long time, it has not progressed, it has not come up with other symptoms, it could be a pressure neuropathy because there is a nerve which comes from here, which goes from here and serves to these two fingers. If the person is habitual to sitting with his hand resting on the arm of the chair, that most of the times that nerve gets pressed there, and because of which he could be having. But it needs to be duly investigated and checked by a neurologist to rule out other factors.
Okay, ma'am. Ma'am, one of our viewer wanted to know about the recent advances in stroke management.
Yeah. So that's good. Stroke treatment has made a paradigm shift now. It is not what it used to be. And now we are able to save so many patients if they are brought in time. Now that includes, for the viewer, is that the pre-stroke care, because now in many centers, and we also wanted to start it actually, once the patient has a symptom, from here the patient informs the stroke ready hospital here, and from where when the stroke ambulance goes, that is known as the pre-stroke care. Here itself the examination and the scale starts off for the patient, and from here by the time the patient gets transported into the hospital itself, we know a couple of symptoms. We know his blood pressure, we know his sugars, we have his ECG, we have his baseline NI stroke scale, and by the time patient comes into the hospital, he has already got an IV line into him, and the patient is taken into the radiology suite, so that we have the imaging factors and can immediately be. The major breakthrough which came was initially the thrombolytic therapy was 3 hours, but many trials were done, and the new trials which showed that if the stroke window period got expanded from 3 hours to 4.5 hours, so the patients have the safety period of 4.5 hours. But having said that, it's not that 4.5 hours means you reach the hospital in 4.5 hours. The door to needle time, that is when the patient reaches the hospital emergency, and by the time the patient the history is taken, the patient's assessment is done, the patient goes into the radiology report comes, the patient gets back into the emergency again. We talk to the relatives, tell them, explain to them about the pros and cons of the thrombolytic therapy. It takes about 1 hour. So the patient, as soon as the symptoms happen, he needs to rush to the hospital, not at the 4.5 hours, because 4.5 hours is the window period. So apart from the medical thrombolysis, which the window period expanded, we have mechanical thrombectomy, which has made a great change in patients with large vessel occlusion. In the patients with the intravenous thrombolysis, if the large vessel has not opened up, in that select patient, they can be immediately taken up for mechanical thrombectomy, and the clot can be removed and a stent can be placed there with the retriever.
Nice, ma'am. Nicely explained, ma'am. Ma'am, our next question is, how would you diagnose the cytopathology in a stroke patient, and how do you follow up in such stroke patients?
The cytopathology are two. One is which area is involved, and second is what is the reason for stroke. As a neurologist and as a stroke specialist, we target these two. Which side of the brain is involved, whether it is subcortical or cortical or brainstem, or any other areas. Apart from that, what is the reason? Whether it is atherosclerosis, whether it is heart, that is cardioembolic, whether it is a lacunar stroke, that is small vessels, that is the lipohyalinosis and the end arteries are being damaged. Or there are other reasons, as I said, angiitis, hypocoagulable state, or coagulopathies, or other reasons for that, or undetermined causes is also one area where with the multiple investigations, sometimes we are not able to find out the reason for the stroke in some patients. So these two patients have got different treatment in a different way, and they have to be followed up differently. Because if the patient has got a cardioembolic stroke and needs to be on blood thinners which are anticoagulant, they need to be reviewed very early, so that their level of the that we do a test called as a prothrombin time with an INR, which needs to be 2.5 to 3.5. So we need to have frequent visits for the patient, and we need to tell them that if they have any bleeding, they need to rush to the hospital. If they have any symptoms, they need to rush to the hospital. The other patients who are on antiplatelet and statins, if they are gradually getting normalized and they are understanding the importance of physiotherapy, occupational therapy, speech, they are doing at home, they're getting mobilized, they're getting back to work, then we increase the number of visits, and there are lesser visits for them, because they have understood the stroke care by themselves, the family and the caregiver and the patient, they can take care of themselves. So they did not come to the hospital very frequently. If symptoms are not subsiding and new symptoms are occurring, then we need to know that this patient could be an ICAT sort of disease, having a severe atherosclerosis, and patient is at a high risk of having recurrent strokes. This patient should be kept at very short intervals, and we need to follow these patients very frequently. So it is different for every patient depending upon the type of the stroke and also the cause of the stroke.
Thank you, ma'am. My next question is, what are the subtle uncommon symptoms of stroke, and how is the transient ischemic attack current investigation algorithm?
Sorry, I couldn't get the first part of the question.
Yeah, the first part of the question is, what are the subtle uncommon symptoms of stroke?
So the subtle, yeah, okay, fine, yeah. So what are the subtle uncommon symptoms is the mimics, what we are saying. Sometimes what happens, there are mimics and chameleons. Sometimes the patients have got stroke symptoms but look like some other disease. They are syncope, sudden onset of fall, the patient becoming unconscious suddenly, the patient behaving extremely irrelevant and like an encephalopathic, like abnormal behavior, psychotic behavior, and the patient having just sometimes just a wrist drop like this or just a foot drop like that, or the patient having severe giddiness, sometimes are missed to have vertigo or any of these symptoms. These are known as chameleons. They could be stroke symptoms if they have happened suddenly, and if they are in a patient at a risk factor, they should be immediately rushed to the hospital. TIA algorithm is different. Actually, once the patient gets into the hospital, we have got an ABCD2 score, which we do for the patient, and that is individualized for each patient according to the ABCD, which has got, like that is the age, the blood pressure, the clinical features of the patient, diabetes, and the duration of symptoms for the patient. And according to that, if we keep ticking, and if the score is above a certain level, the patient needs to have hospitalization, because the recurrence rate of the patient at the 2-day to 90-day interval would be different for that particular individual. We need to have extensive carotid and vertebral Doppler tests for that individual.
Right, ma'am. Thank you, ma'am. So, ma'am, our next question from one of our viewers is, what is the importance of occupational therapy in rehabilitation of stroke? Similar question was also asked, like what could be the role of an occupational therapist in rehabilitation of stroke?
Yeah, as I mentioned in my talk itself, stroke is comprehensive. Once you're given a thrombolytic therapy and given a tablet to the patient, the stroke care doesn't end there. The physiotherapist and occupational therapists have got a great role in getting the patient back to his feet. And it is very important. Physiotherapy is getting back the weakness to his normal state. Occupational therapy takes the motor and the sensory modules into and amalgamates them and takes the patient, so that whatever the patient had de-learned, that is, let me say, using the computer, cooking, sewing, dressing up, grooming, everything, that the occupational therapy will get back that motor and sensory and amalgamate them and get the patient back to his normal. So it is extremely important. In a given individual, given the deficit, it is taken care.
Thank you, ma'am. So, ma'am, our next question is related to speech apraxia in stroke. So, there are two parts of the question. So, what are the recent advances in stroke rehabilitation and speech apraxia? And the viewer also wanted to learn more and grow in the field of rehabilitation.
Yeah, absolutely. I think it is one of the areas which is very raw in our country, and we need more people like you to help us in the stroke care. Speech apraxia, as our participant is speaking, is something which is in which there is no weakness, but the person is not able to talk, and that needs different. That needs again occupational therapy and speech therapy amalgamated into it. Not much of trials have been run into that, into this, but there are certain modalities of investigative trials which are being, but less is being done on this.
Right, ma'am. Ma'am, our next question is, one of our viewers is asking, there is right-sided hemiplegia. So how much total recovery can be expected in hand and gait pattern?
As I said in my talk, that it depends upon the size, extent. Apart from that, it depends upon the comorbidity of the patient, patient's hypertension, diabetes, whether his other side of the brain doesn't have any silent stroke. When was the physiotherapy initiated? Was the treatment given in time? Whether the patient is taking the treatment in time? How much is the patient being mobilized? And for that matter, how much is the patient's willingness, and how much is the patient's incentive and patient into the physiotherapy and moving forward? All that things take into view. If that, there is always a standard and steady sort of improvement which goes over time. It doesn't stop. It doesn't stop at 3 months, 6 months. It continues to go. The tempo might slow down after a period of time, but it keeps going, and we need to continue with the care.
True, ma'am. Ma'am, our next question is one of the clinical scenario. One of our viewer is asking that my sugar level sometimes drops drastically and my body becomes very weak. So could it be a stroke? And the preferred language is Telugu.
ఒక్కొక్కసారి షుగర్ లెవెల్ బాగా తగ్గిపోతే మనకి చెయ్యి కాలు వీక్ అయిపోయే అవకాశాలు ఉంటుంది. ఆ సమయాల్లో మనకు అట్లా కనిపించేది ఇది స్ట్రోక్ సిమ్టమ్ లాగా, కానీ అది స్ట్రోక్ గా ఉండకపోవచ్చు. బట్ అన్నిసార్లు అట్లా షుగర్ తగ్గిపోతానే ఉంటే మోస్ట్ ఆఫ్ ద టైమ్స్ స్ట్రోక్ వచ్చే అవకాశాలు కూడా ఉంటుంది. సో ఇట్ ఈస్ వెరీ ఇంపార్టెంట్ మనం షుగర్స్ కంట్రోల్లో పెట్టుకోవాలి. షుగర్ తగ్గిపోయే కారణాలు కనుక్కోవాలి, మీ డాక్టర్తో డిస్కస్ చేయాల్సి వస్తుంది. ఎందుకంటే అన్నిసార్లు షుగర్ తగ్గిపోతే బ్రెయిన్ లో వేరే సార్ట్ ఆఫ్ డ్యామేజెస్ కూడా వచ్చే అవకాశాలు ఉంటుంది. అది స్ట్రోక్ సిమ్టమ్ కాకుండా వేరే డ్యామేజెస్ కూడా ఉంటుంది. హైపోగ్లైసెమిక్ సిమ్టమ్స్ ఆఫ్ ద బ్రెయిన్ అది ఉండదు.
Okay, ma'am. Ma'am, our next question is in one of the clinical scenarios. So our viewer is asking that my mother is diagnosed with mild lacunar stroke and she is fine on medications. So is there any chances for future stroke, and how would you deal with lifestyle modification after experiencing a mild stroke in the past?
As I mentioned, lacunar stroke is a small stroke at the end-on blood vessel in the brain. So if the large blood vessels are affected, that is a different type of stroke where we have a large stroke in one side of the brain, either side of the brain. When the blood vessel are end-on and there is a small area which can, but then that small area could be leading to one side complete paralysis also, because all the fibers go from that small area of the brain. As I said, even if it is in the beginning of the size, even if it is small or big, it is also important the site. So the lacunar stroke is usually because of hypertension, diabetes, and lipohydrosis. So we need to check and keep this absolutely under control. Walking and lifestyle is very much important for these patients because it is directly related to hypertension and dyslipidemia in these patients. And continuous and compliance and good control of the lifestyle risk factors should be enough for them. Dietary lifestyle I have already mentioned. They don't have a different lifestyle from the other dietary lifestyle from the other patients of stroke. They are the same.
Thank you, ma'am. Ma'am, one of our viewer is asking about one of the scenario that last week his friend lost his mother at Lucknow, and it was a clear-cut case of hemorrhagic stroke. Despite she was admitted to Command Hospital, and the death occurred within 25 minutes of the attack. So what could be the reasons probable, and in old age, how can we prevent all these mortalities? So the third part of the question is any drug that we can keep handy in our home so as to reduce the mortality or disabilities.
I'm very sorry for the loss of the person. Unfortunately, in some cases, we cannot do anything. As mentioned, that it was because of the intracerebral bleed. So the intracerebral bleed means that second type of stroke, and if the blood clot happens in the main area of the brain, that is the brain stem, sometimes it is difficult to save the person because the respiratory and the cardiac centers are there in that area. Now, what can we do to see that these things don't happen? As I said, risk factor assessment of the person and keeping them in check. I have hypertension, I should take the medication for hypertension. At a particular age itself is a reason for hypertension. We cannot run away from that risk factor and we need to keep them in check. Unfortunately, there is no pill that we can give to see as a first aid to prevent any of these. They have to rush to the hospital. Hopefully, at some point of time, we would be able to, there are certain trials which are running. As preventive measures, as a polypill trial is running. Hopefully, we'll have the results shortly, and which we feel that can be given to people at higher risk so that they do not have these catastrophic events.
Okay, ma'am. Thank you, ma'am. Ma'am, our next question is, what is the emergency management of stroke, and what are the options that are available in ECs and CACs? So the next part of the question is also that, is there any first aid available for the same? And if it is a yes, then how long can it work?
As I mentioned in my talk, there is no first aid. The first aid, what the person should do is time the time of stroke, see the deficit of the stroke, do not give anything by mouth, keep the person little head high, keep him on the side so that if he vomits, whatever happens, take all the prescriptions or ask the person to WhatsApp whatever the prescriptions are there immediately while the patient is being transported. Take the patient to the stroke ready hospital and do not hop, skip and jump from one place to the other so that time is not wasted. While the patient is in transit, it is important to know, and especially now in COVID-19 times, I should also be telling everybody that kindly find out which are the hospitals who are catering to non-COVID patients and who are exclusively for COVID-19 patients, because it will also again save the doctor the misery of telling that no, we cannot take because the emergency is full with COVID patients. We don't want these patients to get infected. So find out which are the hospital, which are that would be as a order which would be given by the district collector of that area, that these are the hospital which are catering to both. So take to that hospital which is the stroke ready hospital, and time is brain.
Thank you, ma'am. Ma'am, our next question from one of our viewer is, can a paralytic patient be cured fully, and do brain surgery helps? And also, the other part of the question is, can a right-sided facial paralysis patient recognize his family members and the incidents going in around?
Yeah, surgeries are done for patients whose stroke are so big that the volume of the stroke becomes so big that the brain, the skull is not able to hold them. So they have to take a part of the skull part area so that the brain has a place to swell. So that is a life-saving surgery. So there are several patients in which the surgery has been done in time, where the patient has been able to get back to his normal life to a large extent. So that is one part of it. And the second part, he asked whether there is a patient has got a facial, whether he can recognize. So if a patient has just a facial weakness without the understanding or the speech deficit, then the patient can understand whatever the others are saying, and the patient can also reply to whatever is happening and converse with the family members effectively.
Yeah. Thank you, ma'am. Ma'am, our next question is, even in this modern internet era, after being updated, why still we are unable to treat stroke patients in time? And the preferred language is Telugu.
Yeah. చాలా మంచి క్వశ్చన్ అండి అది. ఎందుకు ఇంత సైన్స్ ప్రోగ్రెస్ అయినాక కూడా క్యూర్ కావట్లేదని కాదు, నేను అదే ఇంతకుముందు చెప్పేది. క్యూర్ ఉంది కానీ పేషెంట్ టైంకి హాస్పిటల్కి రావట్లేదు. దట్ ఈస్ వన్. మనం కూడా స్టడీ చేశాను, దాంట్లో ఆల్మోస్ట్ 80% ఆఫ్ పేషెంట్స్ మనకి విండో పీరియడ్ దాటి వచ్చారు. మనకి ఇక్కడ మన ప్రాంతంలో మాత్రం కాదు, ఇన్ ద బెస్ట్ ఆఫ్ సెంటర్స్లో కూడా పేషెంట్స్ టైంలో హాస్పిటల్కి రావట్లేదు. సో మన ఇండియాలో మాత్రం కాదు, బయట కూడా. ఇప్పుడు థ్రాంబోలిటిక్ థెరపీ ఉంది, మనకి క్లాట్ బస్టింగ్ థెరపీ ఉంది, అందరికీ తెలిసాక కూడా టైం చాలా కాసెస్ ఉండొచ్చు. పేషెంట్ ఫ్యామిలీ రికగ్నైజ్ చేయడానికి లేట్ అవుతుంది, తర్వాత ఎక్కడికి వెళ్ళాలి అది ఆ ప్రాబ్లం ఉంటుంది, ట్రాన్స్పోర్ట్ ఫెసిలిటీ ఉండదు. ఇప్పుడు రిమోట్ విలేజ్ అయితే మనం ఎట్లా వెళ్ళాలి, బండి ఉండదు, 2-వీలర్లు ఎలా పెట్టి. సో ద రీజన్ ఇస్ మెజారిటీ పేషెంట్స్ స్ట్రోక్కి రావట్లేదు. సెకండ్ ఇస్ ఆ డిజీజ్ సివియారిటీ మీదే ఉంటుంది. దట్ ఈస్ వై మనం అందరూ కూడా చెప్పేది, నాట్ ఓన్లీ ద వరల్డ్ స్ట్రోక్ ఆర్గనైజేషన్ ఆల్సో సేస్ దాట్ ప్రివెన్షన్ ఆఫ్ స్ట్రోక్ ఇస్ మోస్ట్ ఇంపార్టెంట్. ఎందుకంటే ఉండే రిస్క్ ఫ్యాక్టర్స్ మనం ఒక స్టేజ్ దాటిపోతే, సివియర్ ఎథెరోస్క్లెరోసిస్ అయిపోతే, కొన్నిసార్లు మనం ఏ మందులు పెట్టాక, ఏది క్లాట్ బస్టింగ్ థెరపీ పెట్టాక కూడా ఆ క్లాట్ అక్కడి నుంచి ముండిలాగా క్లాట్ అయిపోతే మనకు కష్టమే అవుతుంది. సో ఇట్ ఈస్ బెటర్ మోస్ట్ ఆఫ్ ద టైమ్స్ అది పేషెంట్ అంటే ఇన్ జనరల్ ఐ షుడ్ సే నాట్ పేషెంట్ అయ్యే ముందు పబ్లిక్ లో ఉంటుంది, దట్ దే కీప్ ఆల్ ద రిస్క్ ఫ్యాక్టర్స్ అండర్ చెక్.
Thank you, ma'am. Ma'am, our next question is, how do you differentiate stroke from COVID? The preferred language is Telugu.
స్ట్రోక్, కోవిడ్ వేరే వ్యాధులండి. COVID-19 ఇప్పుడు ఒక పాండమిక్ మనకి ఇప్పుడు ఉండేది, అది మోస్ట్ ఆఫ్ రెస్పిరేటరీ, లంగ్ అండ్ హార్ట్ సమస్యలే ఉంటుంది. పేషెంట్కి ప్రిడామినెంట్గా నరాల సంబంధి ఏమీ ఉండదు. కొంచెం నీరసము, అలసిపోవడం, టైర్డ్నెస్, తలనొప్పి అదన్నీ ఆ జ్వరంలో ఉండేది. కాబట్టి కానీ 2 సెపరేట్ సిమ్టమ్స్. ఆ పేషెంట్‌కి స్ట్రోక్ ఏమన్నా రావచ్చా? అది వేరే విషయం కానీ ఆహ్, ఈ 2 వ్యాధులు సెపరేటే.
Thank you, ma'am. Ma'am, our next question from one of our viewers is, can Bell's palsy leads to stroke? The preferred language is Telugu.
బెల్స్ పాలసీ అంటే స్ట్రోక్ సంబంధి వ్యాధి కాదు. బెల్స్ పాలసీ అంటే 7వ నంబర్ నరము చెవి నుంచి ఫేస్‌కి వచ్చేది ఏదో ఒక పక్క వైరల్ ఇన్ఫెక్షన్ వల్ల ఆ పక్క ఫేస్, ఐ, ఫోర్ హెడ్, ఐ, ఫేస్ ఈ ఫోల్డ్ మాట్లాడడానికి ఇదన్నీ వీక్ అయిపోతుంది. దానికి ట్రీట్మెంట్ మనకి మెడికల్ ట్రీట్మెంట్, అది కాకుండా ఫిజియోథెరపీ ఆ నర్వ్‌ని స్టిమ్యులేట్ చేసి 2-3 మంత్స్‌తో దాదాపు మెజారిటీ ఆఫ్ ద పేషెంట్ రికవర్ అయిపోతారు. ఆ పేషెంట్‌కి బెల్స్ పాలసీ వచ్చే పేషెంట్‌కి స్ట్రోక్ వచ్చే అవకాశాలు ఉండదు. కానీ ఆ పేషెంట్‌లో ఉండే రిస్క్ ఫ్యాక్టర్స్ మనం చూడాలి. వాళ్ళకి షుగర్ కంట్రోల్‌లో ఉందా, డయాబెటిస్, హైపర్ టెన్షన్ ఇదన్నీ ఉంటే అది రిస్క్ ఫ్యాక్టర్స్ వల్ల స్ట్రోక్ వచ్చే అవకాశాలు ఉంటుంది.
Right, ma'am. Ma'am, our next question is, can blackout lead to stroke or is it due to stress?
That's difficult to say. Can it lead to stroke? And it's a good question. And blackout can lead to stroke if that is the etiology for blackout. And patient suddenly falls down and becomes unaware. Adi manaku mari, if the person is under a lot of stress, the patient has not eaten well, the patient is hypoglycemic, patient is dehydrated, has been standing for a long period of time and has developed a hypotension, that period of time can also develop a blackout. But depending upon the situation and the other comorbid features the patient has, the patient needs to go to the hospital. We need to have simple blood tests done on the patient and need to check the blood pressure in sitting and standing to see if there is any postural drop of the blood pressure. Need to see the age of the patient and need to see that there could be any other cardiac risk factors in the patient. And then we need to see whether the patient is at risk of stroke.
Right, ma'am. Thank you, ma'am. Ma'am, our next question is, if a person has an episode of stroke, how do you differentiate between whether it's a ischemic stroke or a non-ischemic stroke without any diagnostic test?
Well, that's difficult to differentiate, and there is no need to differentiate also because there's no first aid we are going to give anyway to the patient. The patient needs to rush to the hospital because the treatment modalities are different for both of them, and it is purely based on imaging. In a general consensus statement, if you want to say, is that a patient with hemorrhagic stroke would mostly present with high blood pressure. It's like malignant high blood pressure, and the patient would have severe headache, vomitings, and patient most of the times about in a comatose state. But then that's not the rule of the game. They can be different in different sittings and scenarios.
Right, ma'am. Thank you, ma'am. Ma'am, our next question is, in which age stroke will occur or it's most common, and what's the role of heredity in stroke?
As I mentioned, now age is not a criteria for stroke because we are seeing more and more young stroke so it can happen from age 25 and above in patients. Hereditary in a small number of patients have been seen. There has been familial atherosclerosis, family history of stroke in some patients. Some of the coagulopathies which have got a genetic basis for them. Some of the hereditary disorders like homocystinuria, which can be leading to the stroke, but they are a small number. And once the patient gets a stroke and being evaluated, once the traditional risk factors are not found, we tend to take a second step and find out whether the patient has got any of the hereditary risk factors for him.
Yeah, right, ma'am. Thank you, ma'am. So, ma'am, our next question is one of your clinical scenario. The viewer is asking that my mother got ischemic stroke in 2016 and she is a diabetic and a hypertensive patient, and she is on medication on time from then, and she was given aspirin and clopidogrel for 1 year, and later she is taking medication only for hypertension and diabetes. So is there any chances for ischemic stroke again if she didn't take that medication on time?
Yes, I think the patient needs to consult again. Maybe somewhere out of oversight, the patient might have stopped those medication. The patient has to be strictly on antiplatelets and statins. Kindly consult your neurologist immediately.
Right, ma'am. Thank you, ma'am. Ma'am, our next question is, due to age, how would you consult a doctor through telephone? So the preferred language is Telugu.
వయసు వల్ల టెలిఫోన్లో కన్సల్ట్ చేయాలంటే ఓకే. ఇప్పుడు వయసు అయింది, COVID-19 ప్రాబ్లమ్స్ ప్రకారంగా మనకు హాస్పిటల్‌కి రావడానికి ఇబ్బంది అయితే, చాలా డాక్టర్స్ ఇప్పుడు టెలి కన్సల్టేషన్ యూజ్ చేస్తారు. ఈవెన్ గవర్నమెంట్ కూడా అదే చెప్తారు. ఎందుకంటే అందరూ హాస్పిటల్‌లో వచ్చి కూర్చోవాలి అవసరం లేదు. సో మీరు ఫైండ్ ఔట్ చేయొచ్చు. మీ డాక్టర్ టెలి కన్సల్టేషన్ అవైలబిలిటీ ఉందో టెలి కన్సల్టేషన్ చేయొచ్చు. కానీ అది రూటీన్ కన్సల్టేషన్స్ మాత్రమే ఉపయోగపడుతుంది. ఎమర్జెన్సీ సిచ్యువేషన్‌కి ఏది టెలి కన్సల్టేషన్ ఉపయోగపడదు. ఎందుకంటే ఎమర్జెన్సీ సిచ్యువేషన్‌లో ఫోన్‌లో చెప్పడానికి ఏది మెడికేషన్ ఉండదు. ఎస్పెషల్లీ ఫర్ ద బ్రెయిన్. ఇమ్మీడియట్‌గా మనం హాస్పిటల్‌కి వెళ్ళాలి. ఏదైనా అయితే హాస్పిటల్. బట్ రూటీన్ ఇప్పుడు పేషెంట్‌కి ఓల్డ్ స్ట్రోక్ పేషెంట్, మామూలుగా హెడేక్ ఉందా, బ్యాక్ పెయిన్ ఉందా, పార్కిన్సన్ పేషెంట్ ఉందా, మూర్ఛవ్యాధి పేషెంట్స్ ఉన్నారు, వాళ్ళని రూటీన్‌గా టాబ్లెట్స్ వాడాలి, ఎంతవరకు వాడాలి, ఈ కన్సల్టేషన్ టెలి కన్సల్టేషన్‌కి చేయొచ్చు.
Right, ma'am. Thank you, ma'am. Ma'am, our next question from one of our viewers is why stroke will come majorly in the earlier hours or in the morning?
So most of the patients, we have seen that the patient comes in the morning hours. We call it as a wake-up stroke also. The patient is found on bed with a stroke. So most of the times we don't know what time the patient has a stroke as well. So that's a very difficult situation for us also to give the thrombolytic therapy, because the time of onset of the stroke is not known in those cases. Now, why does this happen? Because most of the times there is a BP surge that happens because of the circadian rhythm, that is a periodicity of our blood pressure, in which it is usually it goes high from the early morning before the wake up hours to the noon period, and then it tends to gradually come down. So if the patient is hypertensive and then on that hypertension there is a sudden surge of blood pressure at that time, the brain is not able to hold that, and then the autoregulation of the blood pressure does not happen, and it gets cut off, and the patient develops a stroke at that point.
Right, ma'am. Thank you, ma'am. So, ma'am, our next question is there any special care during COVID times we have to do?
The special care during the COVID-19 time is that, one, all stroke patients kindly take your medications in time, your antiplatelet and statin. If a doctor is available through the online consultation, kindly get to your doctor and talk to him and take your medication. Keep your blood pressure and sugar in check. Have the blood pressure machine at home so that you can check it manually. A digital would be good enough to know a rough idea of how your blood pressure is behaving. Check your sugar. Try to check your sugars at home so that you don't need to go to the lab and check. Have ample amount of exercises. One cannot go out now, and we are not supposed to go out. But then there is ample space at the house itself, and if you have a terrace, kindly walk around in the terrace if there's no one around you. Eat healthy, think healthy, and be healthy. So if everything is in place, a stroke patient need not worry about anything, because most of the patients are stable. Do not forget on your physiotherapy while you are at home. As I said, we have the stroke help. You can download, you can get logged in and enroll it from the drbindumenon.com website. But only after you take your opinion from your neurologist and your physiotherapist, because we don't know your deficit. But this is just a help for you so that you can do those exercises at home. Do not forget the exercises, because they are very important. Otherwise, post-stroke complications will come.
Right, ma'am. Thank you, ma'am. Ma'am, can we take another two questions, because of the paucity of time we can't take, because there are many number of questions. They are still in the chat box. One of our question is that for cerebellar stroke prognosis, and how would you compare between the pharmacological treatment and the intervention neuroradiological management in cerebellar stroke prognosis?
So person has written, kindly elaborate on comparison between pharmacological and interventional neuroradiological management of stroke. So we are talking about whether we want to give only intravenous thrombolysis, or we want to just do the thrombectomy for that patient. So most of the times we do a bridging therapy. So first we give the intravenous thrombolysis, and if the patient's large vessel does not open up, then the patient is taken for a medical thrombectomy. So most of the times in our centers, we do not wait and directly take the patient to the thrombectomy, because in many of the patients we have seen the large vessel occlusion also opens up. So a medical is good enough. We do not have any head-to-head trial for that. In many of the centers, it is not possible, because there's ethical reasons that why did we not give the patient a treatment which can be given at that 4.5 hour period. So, and So above what age and what frequency should we go for regular screening and assessment for stroke risk? If the patient has got risk factors, then he should go at that age. So if the patient has got hypertension, diabetes, he smokes, and it consumes alcohol, he's sedentary, and any of these risk factors he has, then he should go for a stroke risk assessment at an early age, that is less than 40. Otherwise, in a given individual at 40 years, he should have at least one health checkup done to know the baseline level of where he stands.
Right, ma'am. That will be our last question. So it is from Dr. Salma. So she's asking, if a person of age 46 years, he is hypertensive, complaining of pain at ring finger and radiating through the hand and whole body pains. And there is also little headache. So they had already gone through ECG and 2D echo. So they are normal. So, but is there any risk or especially neuro risk for him? So
now, we wish to say that stroke is painless except for headache. So one symptom, except for this tingling, paresthesias, which is one-sided. So usually stroke is painless. So if you see the B fast mnemonic also, there is nowhere there is pain except for the headache. So if there are certain symptoms, as she has mentioned, the doctor has mentioned, from here it radiating onto the hand, then we need to check whether there is a cervical radiculopathy in that patient. And we need to first examine him, and then we need to subject him to the required investigative modality, so that we know whether any particular disc that is the cervical radiculopathy, and then we need to give him the treatment.
Right, ma'am. So thank you, ma'am. That was from the question answer session, and it was, I must say, it's an excellent educative talk, and then it's very informative. So it's self-explanatory, and the way you have explained it's like everybody will definitely have very good takeaways from this session. So thank you very much, ma'am. So, and then over to you.
Thank you very much. I thank each and every participant. I thank Vishwajit, who took care of all the questions and put them systematically for us to go through it. I wish everybody to have good health, good physical, mental health, and thank you for listening to me and being partners to see that stroke can be reduced to a large extent. And I hope that whosoever has been a part of this session, go back and educate another 4 or 5 members, so that we see that you become the stroke ambassadors. Thank you very much. Thank you, everybody.
Thank you, ma'am.